I've had the title read out, so I'm going to just talk about a dementia care clinic that we've developed. I'm just going to go a little bit about what the background is and developing it, and then thinking back on what we've done and where we'll go to in the future. So the background. So what we did out at Ballarat Community Health, and I'll just say up front first, everyone's heard the building blocks over there and around the place, and the enhanced nurse clinics supported by APNA. We were one of those projects, and I'm just going to talk today about some of our experiences. So the Memory Health Support Clinic, it was a model of care describing the practice nurse role in what we can do to support people with chronic disease management, but people living with dementia. And I was just going to say, the reason I called it the Memory Health Support Service, some people ask me, is it is about people with dementia, diagnosed or not diagnosed, but you don't want to, as the people know, it's quite confronting to talk to people about what's happening with their memory and behaviour. So we sort of targeted it more about memory health and support, because the first thing people tend to talk about when they come to you and they're worried about their cognition is memory. And it's often easier to break into that conversation when you start talking about memory and what we can do to help you keep your memory healthy, well, and be able to do things in your life. Now, I don't know what all the roles are out here, but I just invite people to reflect on when they do care planning with people or attend people's wounds or take blood pressures or look at warfarin doses, how often do people actually start talking with the patient about their cognition and trying to get a feel for if things are going a little pear-shaped out there, is it because of, physical reasons like arthritis and accessing machines and using them, or is it a cognitive impairment? Because the way we plan and help people support their illness is, we need to know about cognition. But it's a difficult conversation. So one of the things I want to do through this presentation is maybe give you a few clues that you can take back and start having these conversations with people. First thing is, the most important thing I think is about having a conversation. So when you're talking to someone, starting to pick up those clues, those things that don't quite make sense, and start, just asking a few more questions. It's also really important looking at risk reduction. It's same as cardiovascular, exactly the same. So keeping your heart healthy is keeping your brain healthy. And the peak times for this is around your midlife. And so when you've got dementia or it's starting to emerge, it's becoming too late. You want people at that 45 to 49 health assessment. That's when you want to be targeting people. And it's person-centred, strength-based care planning. That's what we all do. But in dementia care, you're looking at a dyad. You can't look at just the person. You need to look at the carer or the support person, the family as well, if they're available, because it impacts on both. It's about connections, and it may include referral for diagnosis, but that's not our purpose. This is where we are, Ballarat, in the middle of Victoria. Lovely weather at the moment. And Ballarat Community Health, we're a multidisciplinary community health centre. We've got 4 locations. We've got around 6,000 patients, that many GPs and nurses. Got some nice new clinics and some rather strange, it's a circular clinic on the right there. We work in triangles. It's very strange. Isn't this cool? Okay, so why did we want a memory health support service? So we had to identify a need in the community. I'd already recognised this need because I used to work in the community. But I was still quite surprised. You sort of think of people with dementia as being in aged care, residential care, but the majority, 70% of people with dementia are living in the community. 50% of these cases are undiagnosed. So we don't know who they are usually in general practice. We certainly wouldn't pick them up in a database report screen because they're not recorded. There are delays in timely diagnosis and thus appropriate care planning. GPs are usually the first and most frequent point of contact, and I would argue nurses, and we are definitely underutilised, and I think that's a conversation I've heard being talked about throughout pretty much every presentation, is that we are there, we're in 2/3 of GP clinics in Australia, and we can be used a lot better. I was quite impressed with this. This is an idea, this is why it's a difficult conversation, okay? We're not as individuals alone in finding this difficult, or as communities or as health practitioners. International research shows there'll be a first inkling is what it's referred to. So someone, a family member, a friend, the person will start thinking, hold on, something's not quite right here. Can't put my finger on it. It'll take them about 1.9 years on average before they mention that concern to their doctor, okay? And then a further, from that first inkling, 3.1 years before there's a diagnosis. Now look, I don't want anyone to rush a diagnosis because it's a big deal to get that label, but I do think that 1.9 years, we might be able to make people feel more comfortable that they will talk to us about this concern. In the boxes below are what research has shown are the concerns and what stops people from speaking up. For example, with the person, you can understand it's that beginning of the slippery slope. If I make out that I might have dementia, I'm in a nursing home before I've even blinked. The doctor, a lot of it's around futility. They think, oh, nothing can be done anyway, there's no supports. And I think that's true in general practice because we don't have the models of care or the resources to talk about it and back it up. Why are you going to open that can of worms? Where are you going to go? There's also a lot about that fear of damaging the relationship. And there's systemic things as well. Briefly, why the delays are concerned. My main one is around, we've just had advanced care planning, which was great because that's obviously crucial in this group, is that if we don't start having this conversation and talking about it, we're doing a huge disservice to our patients because we're taking away the opportunity for them to plan for their future. Then the other one is that there's mismatched care planning. If we're not discussing cognition, we're not considering the impact of it, we're going to go in the wrong direction, which I'll explain or show you pictures in a second. And also poor health outcomes. People living with dementia have in excess of 4 comorbidities. If they've got a cognitive impairment, how are we expecting them to manage those comorbidities to the best possible outcomes if we're taking out that conversation? Another thing around value of a diagnosis is you do need a diagnosis to access some community services. There are access to some medications. They work for some people, they don't work for others, but you've got to get them in at a particular time. And one I'm quite interested in is that if you're not diagnosed, you're not picking people up with this, you're excluding them from research and health policy development. And it's an odd tangent, but I just think everyone's got the right to be involved in decision making at policy levels. And if we're excluding this group as not having a voice, which we so often do, then we're excluding them from future directions in having a say into their care. That's just an odd one. Okay, so why discuss cognition? I haven't got to the model yet. I'm trying to get everyone out there talking about it. I'll get there. So we make assumptions. So for example, if someone comes into us and they're either frail or overweight, and we tend to, as nurses doing our usual care planning routine, think, okay, let's look at a dietitian, get some knowledge here. But it could be they can't use the stove anymore, or the family's turned the gas off for safety and given them a microwave. And it's beyond them to learn that new knowledge. It might be they're not going out and they're so socially isolated. You see, I get nervous up here, I'm getting a twitch. And we might think, lack of transport, they're not driving, so we'll get community transport. But maybe it's lack of confidence. So many times I have people not wanting to go out to their usual bingo night or something, and it's really because they keep forgetting people's names that they should know. And so maybe they need a buddy. Maybe they just need some reassurance that we all forget people's names. Maybe they need a community visitor to support them. Continence is a big one. This is often a tipping point to staying at home, is the carer will say, or the support person, when someone becomes incontinent, that's when I won't be able to cope anymore. So we really want to work on managing that. They most probably don't need a pelvic floor exercises brochure or referral to a continence clinic. It may be that they can't find their way anymore or differentiate the colours. And often, if you think of the bathrooms, they're often white, and you'll have a sink that's circular ceramic, then you'll have a toilet that's circular ceramic, and it can be very difficult to start differentiating. And these are just some pictures. So on the left is what we'd see. On the right, if you've got dementia and you're starting to lose your colour depth perception, it's going to be much more difficult to work out your hallways and your spaces. On the one on the left, again, you've got a white seat against a white background, you're losing your depth perception, you're not going to see that very well, you want the one on the right. Often that lovely thing where we get in handovers and, I don't know, who's district nursing or whatever, that this person is difficult. It could be they're frightened. That shower on the right is most probably full of bugs. Okay, the black mats in front are often perceived as holes, so you're pushing someone into a hole. And so, yeah, I'd be damn difficult too. Okay, not going out, could be scared of falling. A depth perception again, that one, those staircase on the left would be really difficult to navigate. Not eating, last slide here. And I found this a lot doing dementia care in the community, is that those beautiful tablecloths that are covered in flowers and butterflies or food often, or the mats have got foods on them, and then the plate is also patterned. And you might sometimes, if you work in residential care, remember people trying to pick stuff up. That'd be extremely difficult plate to eat off for someone with dementia. And we know we're talking different grades. But, and so if someone's not eating, start asking questions about what's it look like for them, you know, so, and it can be fun, it's just good stuff, okay, convince you yet. The role of the practice nurse, here we are. Why not? I'm very strong advocating for us, I think we're all brilliant, and I think we're invisible as well, and we need to become more visible. We have positive nurse-patient relationships. We've been, I think for 20 odd years or something, Linda would know, we've been the most trusted profession. We have longitudinal relationships so we can see if things start to look a bit odd. We already have an established and effective role in chronic disease management. Dementia fits within that context, and there's clinical practice guidelines and research that show there could be a role. Unfortunately though, that's all they say. They haven't said anything else about what that role could be, which is why we tried to come up with this. I'm just very briefly going to say the methodology was the Plan, Do, Study, Act cycle. I'm not going to go into that anymore, that's what it is. You can always look at it up there. What I tried to do, so when I came to Ballarat Community Health, I wanted all the nurses and the doctors to start having a conversation about cognition. That was it. And it was like I had to try and put it into some sort of framework that people could see, oh yeah, I know how we can do this. So really basically it was the care planning item number framework. So the GP does a consult, they're primed now to say, yes, there's something wrong with cognition, and then they go to me as the dementia care nurse, and then I go through and work out what we can do to support this person in chronic disease self-management and for the carer, and everyone then can live on safely at home. And then I realised, well, and I wasn't thinking this is too out of the box, because I'm thinking we have people that specialise, everyone's got different interests. We've got people that are really good at diabetes management, general practice, we've got people that are the go-to people for wounds. And I thought, yep, I'm thinking on it on that sort of model, okay? And then, this is great. So then I actually, because you can see I can't design diagrams well, I can't do boxes, tables and all that sort of nonsense, so this has gone to a graphic designer, but he didn't get back in time, so we'll work with what we've got. So one of the things why people don't have the conversation is they don't have the confidence. You know, like we're going to start talking about this, people like, oh, how can I ask someone about dementia? Have they got dementia? Well, for one, don't use that word. But so I had to think about how do we change the way we do things. So the top boxes, really what they represent is when we normally do chronic disease management planning, person-centred care, we look at their health status and we look at the person's story. All right, so we already do it. We already do those top two. What I'm saying now to people is, okay, start thinking a little bit. Is the reason this isn't working because of cognition, okay? So then, and like those examples I showed you, those pictures before, is there some sort of solutional plan in that sort of way of thinking? If yes, then you're going to do a cognitive assessment and you're going to reflect back on that information you've already got just to see, is there anything here I should be revisiting, okay? Then if there's a support person, you need to include them. And then out of that, and then the future planning, the advanced care stuff I've kept separate because it is so important. And then what you have is a cognitively aware chronic disease management plan. Okay, so that's all that's supposed to say. Now with that, with every box, I have developed a hint guide. So as you get to each stage, I don't know if it's the next one or not. No. Okay, well this is it. So one of our geriatricians who has been a huge champion of my project, and without him I wouldn't be this far, I'll acknowledge him properly later, he developed a dementia pathways tool. This was some years ago, and I could not believe it, of course. Lo and behold, there was no nurse in it. And he developed it for general practitioners to support people with dementia in the community. And yeah, there was no nurse. And so I went to him and I said, look, the nurse needs to be included in this tool, and it's an online tool. It's freely available to anyone who wants to use it, and that's the thing. The nurse isn't quite in there yet because I haven't quite finished it, but by the end of the month, she will be and he will be there. And what it gives you is, and this is just a snapshot off the site, is when you go in, if you click on the button that says Practice Nurse Assessment and Planning, it'll give you those boxes I had in the previous diagram. You can click on any one of those boxes and it will tell you, it'll give you hints then about how to explore things, how you could ask particular questions, and then it will also give you what referrals you could do and what resources you could go to, okay? So it'll give you links to them, and we'll see how it works. So, I thought I was going great guns here. I'd identify that it's a gap. The practice nurse can meet that gap. Research and literature supports that. And so we got a model, we got a resource, we got a practice nurse with some dementia knowledge, and we've got a defined pathway of care. And then I'm like, that's not going to work. Because, I just throw this in, you've got to look at things from different angles. For any postgraduate students here, they'd like that. We all like that. So, and that's another one because I couldn't decide which one to use. But here we go. So what I'd gone and done is I'd take cognition in my pathway out of the whole. Actually, I did just realise now I've done this, I should have put that other model after this slide. And the risk is, and this is where I'm thinking about the title about everything connecting, is chronic disease care planning is holistic, it's person-centred. Dementia is part of the person. And it's progressive. So at what stage do you say, right, I'm doing a diabetes care plan or a dementia care plan or something on this person? And also it impacts so much on all the other health management. So I then took all the care plans and I put the cognition assessment into them, okay? And so it becomes integrated. And so the idea is dementia adds complexity. And you also don't want to take people out of the whole because of that whole stigma and the society values anyway that they're different. And they're not. People with dementia aren't, they're the same as us, they've just got different contexts. So I put what I ended up doing was saying, and don't worry about this too much because I'm running out of time, sorry, that everyone now, so I provided training and developed a training that every practice nurse now in Ballarat Community Health has the basics of how to ask the question, because that's the hardest thing people say is how do I ask these questions? And really what they can be as simple as is you're having this conversation and the husband's saying, oh, my wife, she used to cook such great meals all the time. Oh, so you don't cook anymore. Can you tell me some more about that? And you gradually drill down and you'll find out, 15 minutes later, they'll suddenly pipe up and say, oh, look, I just find it too hard. I can't follow the recipes anymore. And you've got it. You've got in. And then you can start exploring, is there ways, do you miss it? Do you want to be cooking? Are there things we can do? Can we get someone in to help you, You can get people in to work with someone cooking. And then you've started to have that conversation and identify that without coming out and saying, oh, do you think you've got dementia? There's other ways of doing it, and it's about what is the impact and what do I do about that impact? So everyone's trained up. You don't need an advanced nurse in dementia care. You need someone who's interested, okay? You need someone who's happy to say and have these conversations. You need someone interested that they want to help that person live to the best ability, independently at home, doing the things that are important to them. And there's, so you need to know, is cognition impacting on that so you can actually truly support that person. So what we have got is, I was going to do the challenge. What we've got then is a set of tools that everyone can use to help you ask those questions, and then when you get the answers, what are some clues or ideas that you can then go on and do? And that's my bottom line, and that's the model. And sure, bringing in these sort of things, there are challenges. The most interesting one I find is that I think as practice nurses, it's really difficult for us to be leaders and innovators and change agents, partly because of the hierarchy, and partly because it's general practice is conservative, but also because everything we do is supposed to be billed, and I have a real problem with that. So I'm interested to see what opportunities healthcare homes might offer us. And on that note, I think coming and learning about what we can all do and from each other about these new ideas and clinics and different care delivery models. I think while the GPs are all up in an array, I've been getting arguing about the capitation of the funding, that if we get organised we can do some really good things. There are rewards, and I think at the end I've just got, no, don't worry about the future, from this morning that we can do it, show courage. And then I've got contact details at the end if they print them. Sorry, a bit rushed at the end.
Thank you, Carolyn. So, I think we've got time for one, maybe two quick questions.
Oh, I've confused everyone. Yes?
I have a question, just what you said at the end about billing. Could a nurse be part of an aged care package? Like, could you spend some of your aged care on asking a nurse to consult with you if you're aged?
If there might be people who know better than me, but I don't think you can as a practice nurse, but you could get in district nursing, so community nurse, and some district nurses groups or services are now having someone who specialises in dementia care. But no, you wouldn't be able to access us as far as the care planning and that. We sort of come in on a different funding. Yeah. Yeah.
Okay. All right, we can certainly chase Carolyn afterwards if people have questions, but thank you. I think the thing that I noted out of that was that dementia will probably be a comorbidity with most things, and so therefore the care planning that is needed needs to not just be disease or based, I guess. So, good.